Hello, everybody. My name is Peter Chen. We have probably met in person by this time, but who knows by the time that this is recorded and sent out to you, who knows if we actually have met in person or not. Today, we're going to talk about toxicology, which is chapter 21 of your textbook. Please, as we go through this lecture, if you have any questions that you want answered when we do our question and answer period, please write down these questions so we can discuss them, whether it's myself or another instructor. All right, our introduction to toxicology is basically it's the study of poisons. We come into contact with poisons every single day. Just walking around the world, in our houses, we have toxins underneath our sinks, everywhere we work, everywhere we live. We have acute poisonings, as we see here, affects over 2 million people every year. And we have chronic poisoning, which is going to be your substance abusers that we deal with on a regular basis, as well as all the health issues that come with people who are chronic abusers of drugs and alcohol. We talk about how do we identify the patient and the poison, all right? So some basic definitions that you see here on your slides. What is a poison? It's any substance whose chemical action can damage the body structures or impair body structures. And usually they add on to that at small amounts. So even oxygen can be toxic at a high amount for long periods of time, but it's not considered a poison. All right. A toxin is a poisonous substance produced by a bacteria, animal, or plant. Substance abuse is the misuse of any sort of substance other than its desired effect. And an overdose is a toxic dose of some sort of drug. This chart basically has some specific signs and symptoms of your overdoses. The big thing about overdoses, while we can treat certain overdoses with things like Narcan for opiates, for the most part for overdoses, we're going to treat the signs and symptoms, maintain and treat ABCs and any sort of immediate life threats. When we have our patient, things that we're going to ask, well as our sample history, we talk about our OPQRS, is we want to ask some specific questions. What did you take? How long ago did you take it? Or when were you exposed to the chemical that might have caused the overdose? How much did you ingest? Did you ingest something on an empty stomach or not, which can determine how fast a drug or alcohol is absorbed into the body? Did you take any sort of antidote prior to our arrival? Did they drink milk? Did they take Narcan? Did they drink water? And for our patients, for toxins, their weight is something that we might want to acquire. When we approach the scene, again, it's always about safety. Safety is always paramount. Your safety, your partner's safety. We don't want to enter some sort of environment in which there's toxins in the air that can cause us harm. But if we're in a house, for example, we can look around for immediate clues, look for suspicious materials, look for containers, look for pill fragments and vomit, look for empty pill bottles, look at the labels on the pill bottles. When was this bottle filled? It was filled yesterday with 30 pills, and today there's only 4 pills in that bottle. And this is what the patient said they took, but they're not sure how many, but you might be able to do some detective work and have an estimate that, hey, maybe they took 20 since there's only 10 left, or 26 if there's only 4 left. How do we treat poisons? Really depends on how they enter the body. Their 4 routes are going to be inhalation, absorption, ingestion, and injection. Inhaled poisons are the fastest acting poisons. Think about anyone that you know who smokes cigarettes. As soon as they take that hit on the cigarette or marijuana, they take a hit on a pipe, they feel that rush straight away. If it's an industrial area or they're in a house, carbon monoxide poisoning or something like that, if it's safe for you to go in there, you want to get that patient out of the house, get them into some fresh air, give them supplemental oxygen. If there's an issue with vomiting, you want to use a nasal cannula. If they can tolerate a mask, you're going to use that non-rebreather at high flow oxygen, 12 to 15 liters per minute. If you suspect there's toxins in the air or in the environment, you stay out, have the hazmat team come in. They need to clear the scene. They need to decontaminate the patient. So when you get that patient, they're not off-gassing any sort of toxins that could make you sick. One of the things that we unfortunately deal with are people who commit suicide in their cars, in their garage, using carbon monoxide poisoning. We have to be careful. That car is full of carbon monoxide fumes. We go open that door, that poisonous gas is going to rush out at us and could poison us. So we want to be very careful in opening those doors to the cars. Absorbed and surface contact poisons. These are going to be these powders, liquids, things that people might have spill on them. Usually these are going to be accidental. They can enter the body through the mucous membrane. Some are transdermal, meaning they can enter the body through the skin. Many times these types of poisons are going to be burning sensations. But understand there are certain drugs that are transdermal. Fentanyl patches, for example. You can put that on your skin and the fentanyl will enter your bloodstream through the skin. Nicotine patches is a transdermal medication. So when you have someone with what we would consider your normal poisoning through contact, you're looking for spills, you're looking for powders that might have gotten on the patient's clothing, and you're looking at systemic side effects because that poison, if it's transdermal, enters the circulatory system and is rapidly circulated throughout the body. Signs and symptoms of contact poisons. Again, the history of exposure, what happened, this box of powder fell on me and now I have this poisonous powder on me. Liquid acid fell on someone. So usually they know what they came in contact with. You have that burning sensation, itching, redness, odors of the substance would be your common signs and symptoms. Emergency treatment, we're going to always protect ourselves. If you can safely, if it's a powder and you can safely brush off the powder, you don't want to make a cloud because then you're going to inhale the chemical yourself. You're going to have the patient inhale it. For powders, you're going to try to brush them off as much as possible. Remove the clothing that they're wearing. If you're lifting a shirt off of someone, you want to pull it over their head from the top, not bring it up from the bottom, where you end up pushing the powders all into their face. To remove all the contaminated clothing and then consider whether or not you need to hose them off. Some powders don't become active or they become more active if they get wet. So if you're going to hose somebody off, you need to make sure you have enough water to dilute that powder so it doesn't burn once you activate it with a little bit of moisture. So you need to have enough water to do a good 20 minutes at least of irrigation. So you can pull that fire hose, you pull that garden hose, ensure that you have good water flow and you spray off that powder and not give it a chance really for it to burn because you're washing the powder off super rapidly. The chemical agent has been introduced into the eye. You're going to irrigate them quickly and thoroughly. It's real important if it's only in one eye that you tilt the head to where the affected eye is at the bottom. So when you're washing the eye off, the fluid that you're using to wash the eye out doesn't go into the unaffected eye. What you see here is a nasal cannula, which is probably attached to a saline bag, a saline IV bag, and they're irrigating this person's eyes at the same time. You can transport the patient while you're doing this. You don't need to stay on scene, assuming that there's no other contamination. In your university settings, your industrial settings, you're usually going to have safety showers, eye wash stations. Hopefully by the time you get on scene, that worker who might have been exposed to this poison has already taken that safety shower, washed their eyes out. You're usually going to have a dispatch that has already sent the hazmat team with you. You get there before the hazmat team. You can assist the patient as long as it's safe for you to do so. You know, if you see that there's multiple people suffering from uh, toxicological emergency, you might not want to enter that scene. I mean, if it's from a spill and you can get them out without getting coming in contact with the spill, you probably can assist. But if it's an airborne toxin, you need to stay away until you have proper breathing apparatus. One thing with all our poisons and chemicals that are used in industrial settings, schools, there is a material safety data sheet. This is a uniform document that every single chemical has, and it tells you what the chemical makeup is of the chemical, how do you treat it if someone is overdoses on it, if they ingest it, if it's in contact. Uh, Especially industrial plants, you're going to have that material safety data sheet for chemical spills. For ingested poisoning, 80% of poisoning is by mouth. It's going to be alcohol. It's going to be overdoses by pills. If it's in children, it's usually going to be accidental, deliberate in adults. And by deliberate, doesn't mean they purposely planned on becoming extremely intoxicated to where they could not stand up. That's usually not what drunks end up planning at the end of the night, but deliberate in the sense that they were purposely drinking alcohol. Signs and symptoms are going to vary depending on what the patient ingested, the age of the patient, and the time that has passed since that ingestion occurred. So let's say we have someone who's ingested some sort of a chemical. We're going to be looking for burns around the mouth, gastrointestinal pain, vomiting, cardiac dysrhythmias, seizures. These are the types of toxicological emergencies. You probably will contact poison control, notify them what the person took, if possible, and they can give you advice on how to treat that ingestion. Sometimes we'll have patients drink milk. Sometimes we'll have them drink water. Sometimes we have them take activated charcoal. It really depends on the direction we're given by poison control or medical control. If you have the bottle, you can look on the bottle to see what it recommends to do if someone has ingested the poison. One thing we do not do is induce vomiting. We have a medication called Ipecac, or syrup of Ipecac, which when you drink it will induce vomiting. We no longer give that to people who have overdosed or ingested poisons because the risk of aspiration or choking on the vomit is too big. So with ingested poisons, as I mentioned, some EMS systems allow EMTs to administer activated charcoal. What activated charcoal will do is bind to what was ingested and prevent its absorption into the bloodstream. And activated charcoal needs to be given within 1 hour of the ingestion. Our injected poison, these are going to be poisons that are injected through needles or by insects. They're usually absorbed pretty quickly. If it's into a vein, it's almost as fast if it's inhaled. So inhaled poisons tend to be the fastest acting, followed by IV injected poisons. If a poison's injected into a muscle, it's absorbed into the bloodstream a little bit slower. One thing about injected poisons, once it's in, it's in. There's really no way to get it out of the body. There's no way to get it out of the bloodstream. Signs and symptoms of injected poisons, again, it's going to vary depending on what type of poisons, whether it's an insect, whether it's a spider, what type of drug was injected. So it can include weakness, it can include excitability, it can cause you to be dizzy, it can cause you to become extremely agitated and hyper. So really it's going to determine what the poison or drug was that was injected that will reflect the signs and symptoms. So what we're going to do obviously is scene safety, PPEs. We're going to assess level of consciousness. We want to know what their level of consciousness is as we get there, and does that change as that poison is absorbed and circulated through the body? Is the person showing decreases in mental status? And as always, we monitor airway, breathing, circulation. So sometimes these patients, it's sort of weird, they're there in the back of your ambulance, and you're not really able to do anything other than give them oxygen and take vitals, because as an EMT, the level of interventions that you can give are limited. And even as a paramedic, there's some medications that we can give for certain overdoses, such as Narcan. We can sedate people if they're very agitated with Versed or ketamine, but a lot of times it's just patient monitoring and treat any life-threatening signs and symptoms as they occur. One thing with injected poison, with IV drug users, you have a lot of skin abscesses. Be aware they inject anywhere and everywhere, so it's important to do that head to toe. Some of them will be very honest. They'll tell you all of their injection sites. Some will lie about being IV drug users. It's amazing how many IV drug users have been bitten by spiders multiple times up and down their arms. Uh, if you see these track marks, which are needle marks up and down the arm or on the leg and the groin, those are pretty good indicators that they're injecting drugs. If you have some sort of injections on the arms or legs, you want to remove things like rings. You want to take shoes and socks off, bracelets. You don't want anything that's going to get stuck or cause issues as that extremity swells. And as that swelling occurs, you want to put a circle around that red swelling area, write the time. Do that about every 10 to 15 minutes if the swelling increases. That way, when they get to the hospital, the doctors can see how aggressive that swelling is. Is the swelling at the site of the injection rapidly increasing? Is it staying about the same size? So it's almost like they have a target on their arm where you have circled that area of redness that may be getting bigger, it may be getting smaller, it may stay the same. With erythema, size up. Again, if you walk in, it's BSI scene safety. Are there odors in the room? Is there drug paraphernalia? Are there chemical bottles, medication bottles, alcohol bottles? These are all things that you're going to look for as you enter a scene. Suspicious behaviors, odors, there's a crystal meth lab, you smell these chemical odors, in some hotel room, some house that might have been rented on Airbnb that was made into a week-long meth lab, things of that nature. So your primary assessment is always going to be the same. You get your general impression, you assess level of consciousness, determine any life threats, which is squirting blood, airway issues, breathing issues, circulation issues. Do not assume that a person who appears to be conscious and alert is actually stable. There are drugs that are given to people now that are disassociative. They can talk to you and answer questions, but this person is actually not even aware of what's going on. When we look at our airway breathing, again, check the mouth, make sure there's no vomit, make sure they're in a position that if they do vomit, they're not going to aspirate. Get that airway open. If they think there's an overdose or ingestion, check the mouth for burns, check the mouth for tablet pieces, anything that could help you with your assessment. And provide oxygen if they're having difficulty breathing. Have suction available in case they start vomiting. And also, you always want to have that vomit bag available, because the last thing you need when someone has started to projectile vomit is to go, hey, where's the vomit bag? You want to assess the pulse and skin condition, get those ABCs out. This is going to be a medical patient most likely, so you want to get that sample history. You want to get that OPQRST answered, so you can determine, okay, is this a rapid transport? Is this I can stay and do some assessment here. So again, if they're not in any immediate life threats, you might be able to take your time at the scene, search a little bit better for anything that might give you clues to what the ingestion or poisoning is about. Contact poison control, maybe actually start treating that ingestion or whatever is going on with that patient at the scene. If it's an ABC issue, address ABCs, make sure the patient's decontaminated, get them to the hospital. And again, everyone who's exposed to the hazardous material must be decontaminated prior to leaving the scene. So unless you're hazmat and it's a dangerous scene, hazmat goes into the hot zone, the red zone. They bring the people out to the warm zone or the yellow zone. They decontaminate the patient. By the time they get to you, they should be in the green zone. They should be totally free of any sort of contamination. So you can take them to that hospital and not contaminate yourselves, not contaminate the hospital. History taking. Again, this is your sample history. This is your OPQRST. If someone is unresponsive, you're going to get clues from bystanders, family members, co-workers, and from the environment. And as was mentioned before, some of the history-taking questions: what is the substance involved? How were they exposed? When were they exposed? What was the level of exposure? Were they in this area for 10 minutes? Were they in this area for 20 minutes? How long have they been unconscious? What's the concentration of whatever caused them to have the medical emergency? Any interventions that were done prior to arrival? And with toxins, weight does matter, so you want to get a good estimate on that patient's weight. Your secondary assessment. This is going to be your head to toe. Again, if they have toxins on their body, remove the clothes, wash them down, get them nice and clean before they get put in your ambulance. One of my experiences with a patient who was not cooperative with the police. They pepper sprayed him with a whole lot of pepper balls. When he was outside of the ambulance, it seemed like the pepper spray had dissipated enough. Once we got him in the ambulance and closed the door, the off-gassing of that pepper spray in the back of the ambulance caused me to start having the same side effects of being pepper sprayed. And when we got that person to the hospital, we had to have him washed down before we took him into the ER, because we didn't want to roll someone into the ER who was off-gassing pepper spray that would cause problems for patients and staff. You get that baseline set of vitals, and depending on their stability, if they're stable, you want to get those vital signs every 15 minutes or every 5 minutes if they're unstable, or if there's any change in that patient's condition. We want to always communicate and document what we saw, what we did, and the results of what we did on our run report. So what type of emergency care are we providing, depending on the poisons that we're dealing with? Again, scene safety, decontamination, look for things like fragments, tablets in the mouth, look for burns in the mouth. You're looking for whatever caused a problem. So again, ABCs. If your EMS system allows you to give charcoal, give charcoal. As I mentioned before, the activated charcoal binds to specific toxins, so they're not absorbed into the bloodstream and they leave the body through the digestive system. There are certain times when we do not give charcoal. The best way to figure this out is by calling poison control. And we do not give charcoal if they have a decreased LOC and cannot protect their airway. When you give charcoal, it's either in a tube or a bottle. It needs to be shaken up because activated charcoal is a suspension. So as the bottle sits, the charcoal will go to the bottom. And so you need to shake it up so it's all mixed into the liquid. And if you're able to, you pour it into a styrofoam cup or some sort of cup with a lid on it where they can't really see it, because they're basically, it's a very black liquid that doesn't look very appetizing or appealing. In my experience, the people who have been able to actually take the activated charcoal, they just take that bottle or tube and just squirt it down their throat. The dose is 1 gram per kilogram. For adults, we tend to give 25 to 50 milligrams, and for children, we do 12.5 to 25. Side effects are going to be constipation and black stools. Again, we don't give this unless it's been within an hour. After an hour, the medication or toxin has already been absorbed into their bloodstream, so activated charcoal is not going to do much of anything. They don't really do what we used to refer to as stomach pumping. With stomach pumping, a tube was basically inserted through the nose or down the throat into the stomach, and they would push sterile water into the stomach and then suck it back up to try to suck up any toxins, the liquids, the pills, or whatever was in the stomach. And they would do that over and over, fluid down the tube, suck that fluid back up, and do that constantly until they thought they got everything out of the stomach. You very rarely see that done anymore. Nowadays, they tend to treat the signs and symptoms of the overdose. They don't do that stomach pumping. All right, so specific poisons. Just depending on when we talk about substance abuse, people who abuse drugs develop a tolerance. Some drugs have develop tolerances quickly. Some drugs don't really have it takes longer to develop a tolerance. Basically what a tolerance is, it requires that you use more of that drug to get the same high as you become an abuser. All right, so drug users tend to also have other issues. HIV, hepatitis, liver cirrhosis tend to be very common in people who abuse drugs and alcohol. Alcohol damage or alcohol. Alcohol can damage the liver. It's not uncommon to have alcoholics have cirrhosis of the liver. You have your binge drinkers that go out every weekend and drink 4, 5, 6 drinks or more and become highly intoxicated. Then you have those people who drink, beers, liquor every single day, that chronic alcohol user. Alcohol is a CNS depressant, so it slows down your central nervous system. Even though with some people it seems like it increases their behavior, basically what it's doing is it's reducing their inhibitions, so they're acting out more, especially with aggression. The saying that, the truth comes out when you're drunk, it's because things that you would not say when you're sober because it would be wrong, you might be more willing to say when you're intoxicated because your brain's not letting those inhibitions take hold. So, but ultimately though, when someone is severely intoxicated, they're going to have decreased brain activity, drowsiness, slower reflexes, reduced reduced reaction time. They can become aggressive, make inappropriate behaviors, make decisions that they would not normally make regarding behaviors, stealing, violence, things of that nature. When mixed with drugs, alcohol has a potentiating or a synergistic effect. You take 1 or 2 Valiums and you drink alcohol, it now feels like you took 6 or 7 Valiums. So you're dealing with a person who is much more under the influence of that Valium than if they had just taken the Valium by themselves. All right, I think most of us here know you drink too much. Many times you're going to vomit. Many times you will black out. One thing with alcohol withdrawal, for someone who's a true alcoholic, it can be a life threat. Alcohol withdrawal is something that really does have to be done in the emergency room or in a treatment center because they have the delirium tremens, which is a DTs. It causes hallucinations. It causes seizures. And if that happens outside of a medical setting, they can go into a coma and die. So a lot of alcoholics, if they call 911, they will tell you, hey, I'm having the DTs. You ask them, hey, when was the last time you had a drink? They're usually pretty honest from my experience. If they're alcoholics, they know they have a problem. They'll tell you when their last drink was. A lot of alcoholics, they do anything for their liquor, for their alcohol. If they can't get liquor, they'll drink hand sanitizer, anything that has alcohol in it. Opioids, we're having a huge problem in this country with opioids. The most common things that we're seeing out here are going to be your fentanyl. Fentanyl is 50 to 100 times more powerful than morphine. It's synthetic morphine. The reason you die from an overdose on opioids is it is a respiratory depressant. So someone who overdoses on an opioid tends to be a very quiet overdose. These patients aren't out there fighting you and acting up. They're unconscious, unresponsive to the point that the breathing slows down and stops, which then causes cardiac arrest. If you can get them Narcan, the Narcan in many cases will push the opiate molecules off of the brain, allow breathing to return, and you've saved the day. In many areas, EMTs can carry Narcan. Out here, most of our police departments have issued Narcan to their officers. In my experience, the police have already given Narcan prior to us being there in many of our case overdoses. You see this table are many of the different types of drugs that are in the opioid category. You see codeine. One of the street drugs that we see a lot with high school kids is something known as lean or dirty syrup. And basically it's codeine cough syrup, which is grape flavored. They take that codeine cough syrup, they throw it into some 7-Up or Sprite, throw in a bunch of grape Jolly Ranchers, mix it all up, and they sip it all night with their friends. It's known as lean because as you're drinking it and you're getting pretty wasted, you start leaning off to the sides. A common thing that you'll see someone who's on opiates is what they call the nods, and they're talking to you and their head just sort of nods down and they sit right back up. I think we've all had that experience when we're too tired and we're trying to read or pay attention to a lecture on Zoom that's just super boring, and you just sort of nod that head off and come right back up. Said one of the good things about opioid overdoses, we actually can treat that in the field in many cases and hopefully reverse that overdose. One thing with opiates, tolerance develop quickly. We see people that go to jail for 3 or 4 weeks, they go through some withdrawal and they get out and they go right back to the same dose they were using right before they got arrested, and boom, they have an overdose because in the 3-4 weeks they were locked up, their tolerance went back down. So they actually needed to reduce the amount of drugs they were shooting up or smoking until they developed a tolerance again, which will develop very quickly. Your classic sign for an opiate overdose is going to be that sleep apnea, or excuse not sleep apnea, an apneic patient, and pinpoint pupils. But not all opiate overdoses will cause pinpoint pupils, especially if the person is a polysubstance abuse user. So they're also smoking marijuana, they're also drinking alcohol, which are going to cause dilations of the pupils. So if you see someone with pinpoint pupils, 99% of the time it is going to be an opiate issue, but just be aware, just because they don't have the pinpoint pupils doesn't mean they're not on opiates. When it comes to treating them with Narcan, which can be given IV, it can be given intramuscularly, it can be given intranasally, it's not going to hurt someone if they don't have the opiate overdose. So if you get someone who's unconscious, unresponsive, barely breathing, you give them the Narcan. If it wakes them up, great. If it doesn't wake them up, you continue to support the airway, you continue to breathe for them, give another dose of Narcan, and let the hospital figure out why they're unconscious and unresponsive. We no longer just give the full dose of Narcan. If the person's breathing and it's an opiate overdose, why give them the Narcan? The Narcan is for that person who's no longer breathing. We don't need to wake them up. We only want to make sure they're breathing. One of the issues of if we wake them all the way up and they wake up pretty quick when that Narcan kicks in is they can now refuse transport. And that fentanyl, that opiate, might still be circulating in the system. And as the Narcan wears off in about 30 minutes or so, if they still have too much opiate floating around their system, they go into another overdose and we won't be there. So very often with these opiate overdoses, we get them to the hospital. As soon as they come around, they just walk out of the hospital anyways, but at least we've done our part and got them to the hospital. But we don't need to just wake them up just to wake them up. If they're breathing, we monitor ABCs, give them supplemental oxygen, and we transport. If they're not breathing or a very slow respirations, we're going to give them that Narcan. But again, we don't need to give them the full dose. We give enough to get that breathing started again and go from there. Your sedative hypnotic drugs, these are your barbiturates, your benzos. They're very easily to obtain. They're cheap. You develop a tolerance on them. They are CNS depressants. They'll alter your level of consciousness. They cause euphoria, drowsy. These overdoses, again, the patients are not combative. They are very peaceful, sleeping, have a breathing, you're going to monitor those airway breathing circulation. The newer sedative hypnotics tend to be sort of hard to overdose on. You know, the old school tranquilizers, you take a couple of them, you drink some liquor, you're dead. Nowadays, a lot of these things like Ambien, you can take quite a few pills. While it'll make you go unconscious, it doesn't destroy your respiratory rate, so you're not going to die from respiratory arrest. You might vomit and aspirate and die, but you tend to just be unconscious and sleeping. So when you get these people to the hospital, it's just palliative care. Monitor airway breathing circulation, let your body metabolize the drug, and you wake up. Your date rape drugs would be in this category also. So again, monitor ABCs, prompt transport to the hospital. Your abused inhalants, these are going to be your chemicals, spray paint, cleaning compounds, air freshener, your glues. There's not much we can do with someone who has inhaled poisons. Basically what happens is the chemical from that whatever they inhaled attaches itself to your hemoglobin. So that hemoglobin is now taking a poison to the brain instead of an oxygen molecule. And that brain starts to act weird. The brain becomes hypoxic basically. So they get lightheaded, they get dizzy and sense of euphoria. Those are going to be those signs of inhalant abuse. Someone's inhaling gas or paint, you can look or smell the chemicals. You can see paint around their nose and mouth. This can cause sudden cardiac arrest or something called sudden inhalant death syndrome. Because as these chemicals circulate around the circulatory system, it can cause some sort of cardiac dysrhythmia that can send them into cardiac arrest. So we do need to be aware that we need to handle these patients gently. We don't want to be bouncing them all around. We want to try to keep them calm so they don't go into cardiac arrest, they don't go into seizures. We're going to treat these people with high flow oxygen to try to push those chemical molecules off the hemoglobin and replace it with oxygen molecule. Hydrogen sulfide, it's a highly toxic, colorless, and flammable gas with a rotten egg odor. When inhaled, it affects all the organs, but it has the biggest impact on CNS, used to commit suicide. If you smell that rotten gas or that rotten egg odor, you exit the scene, let hazmat come in and take care of it. They have a sniffer that they can determine what's the chemical that's in the air. They can clear that air out, make the scene safe. They can bring the patient to you, and you treat that patient, their ABCs. There's nothing we can do other than address the respiratory issues that go with hydrogen sulfide. Signs and symptoms: nausea, vomiting, confusion, shortness of breath, difficulty breathing, loss of consciousness. We're going to bag this patient if needed, control the airway, monitor their airway, be ready to suction, and have to go into cardiac arrest. be ready to do CPR. There is some debate whether or not we would even do any sort of breathing, definitely not mouth to mouth. You want to use that bag. You don't want to be there if that gas is in the lungs, as with anything that's inhaled, as you're bagging that patient or ventilating the patient, the toxins are going to come out of in that exhaled air. Sympathomedics. These are your CNS stimulants that mimic the effect of the sympathetic nervous system. All right, these are going to be your ecstasy, your PCP, your crystal meth, your cocaine, commonly just known as stimulants. These are the patients that are not going to be cooperative. The opiates and the sedatives, these patients, they're passed out, they're unconscious, they're loopy. These patients that are on stimulants, they're aggressive, they're agitated, they're hallucinating, they want to fight you. So these are ones you definitely need to be extremely careful with. So with the stimulants, they're going to do the exact opposite of the opiates and the hypnotics, which are also known as depressants, because they're CNS depressants. And many times people will mix a depressant with a stimulant. Think about your common drinks, Red Bull and vodka, right? You want to get the euphoria of being intoxicated, but you don't want the drowsiness, so you mix caffeine with it. You take speedballing, is the mixture of opiate with cocaine or crystal meth. You want to try that perfect balance where you get that euphoria of being high on heroin, but you don't want to get the nods. So you do that stimulant and you try to find that perfect balance. The problem is the stimulants tend to have a shorter half-life. So as soon as that cocaine or crystal meth wears off, you overdose on the heroin, just still circulating around your system. The only reason you didn't overdose earlier is that stimulant was increasing your respiratory rates, increasing your heart rate, and then the cocaine or crystal meth drops out of the system and the heroin just takes over and boom, you're in your overdose. One of the common old school ways of dealing with the heroin overdose was you threw the person into a cold shower, or you threw ice down their pants in the belief that the adrenaline rush of being hit with cold water or ice cubes would wake that person back up. So it's not uncommon to find someone who overdosed on heroin soaking wet in the bathtub or with ice cubes on them because their friends tried to wake them up by stimulating the adrenaline release. Go back to this category of drugs of stimulants. They produce an excited state. They will cause hypertension, tachycardia, dilated pupils, agitation. You can, drugs like cocaine, you can sniff it, you can inject it, you can smoke it. Immediate effects. Crystal meth is the same. With this increase of the CNS activity, you're looking at the possibility of seizures, strokes, because your blood pressure increases, heart attacks because your heart is now beating 200 times a minute. You get hallucinations, paranoia. These people become very agitated if they're not already. They do not want to cooperate. You need to be very aware of your safety. For medics in our area, we are able to sedate these patients. If they are extremely agitated, we can give them Valium, or as Ari Verse said, we can give them ketamine. Bath salts, which is a synthetic drug, similar to ecstasy. Many times it's sold over the counter. It's really hard to make a synthetic drug illegal because once they make one chemical combination illegal, they just move a molecule and boom, now you have a legal drug again. And since the packages say it's not for human consumption, there are bath salts, there are potpourri. The legal system is, until recently, had a hard time figuring out how to ban these types of substances. Tucson, we had a big issue with them until a couple years ago, and they've cracked down on it pretty good. As soon as people would smoke these, they would take a couple of steps and pretty much just flat out fall on their face and just lay there twitching, basically. As with many of the stimulants, you get the increased mental clarity. They produce euphoria, sexual arousal. One thing, crystal meth, sexual arousal is one of these side effects that you see very often with crystal meth. Before the internet was on everybody's phone, you would go to these houses in which you had crystal meth users, and you would just find tons and tons of porn magazines and videos. Because these guys, they would do their meth, and they pretty much would masturbate all day long. Or if they have their girlfriend there, they pretty much just have sex all day long. Hence, the 4 kids that are just being neglected in that environment or whatever, because they're literally just having sex all the time. It's actually a drug that's also being abused very regularly in the gay community, with crystal meth and Viagra being a combination that you'll see very often. It's actually a drug I've also seen in young people who think, hey, I want to take some Viagra and crystal meth so we can just have sex all night long. You'll see people on these drugs that can be up for days and days at a time, and then they just crash out and sleep for like 3 days nonstop. So you're also going to be dealing with all the issues of dehydration and malnutrition that might come from not eating. A lot of times with crystal meth, they crave very sweet things. So you see the Mountain Dew is a common drink that you see. They grind their teeth, they pick their skin, with another difference that you see a lot with cocaine versus crystal meth. The itchy skin tends to come with crystal meth, and the meth mouth due to the chemicals that are in crystal meth. And if they're doing IV injection, you're thinking you're going to have abscesses in their injection sites. So do your best to keep these patients calm. Just be aware that just because they might appear physically calm does not mean they're calm inside their head. Their brain is moving 1,000 times a minute. Yeah, they cooperated, they get on that gurney, but their brain, they're hearing things, they're seeing things. They think you're there to kidnap them, and boom, 1 minute they're calm, next minute they're trying to jump out the back of the truck on you. So always use your straps when you're transporting. Consider having someone in the back with you for these patients, because they can turn on you pretty quickly. And again, we have chemical restraints as needed to facilitate safe transports. And if it's not safe for you to transport, you don't transport. And if you need to restrain, remember, you need to have at least 4 people to restrain someone safely and properly, preferably 5, so you have someone controlling the head. Marijuana, it's abused throughout the world. You don't really see people dying from marijuana use, but you do have the effects of how marijuana impacts the brain. The executive functioning skills of marijuana are things that you're going to see. You're seeing an increase in car accidents, neglect of children, because the parents can't function and be parents while they're high in many cases. It produces euphoria, relaxation, and drowsiness. It can impair short-term memory. It impairs the capacity to do complex thinking. Ultimately, marijuana abuse will lead to depression, confusion, anxiety, and even hallucinations and paranoia. As marijuana has become legal or decriminalized throughout the country, you're seeing more edibles, and you're seeing more visits to the ER for people who are having anxiety attacks related to marijuana, or there's something, as you see, the cannabinoid hyperemesis syndrome, which is just massive vomiting related to the use of marijuana edibles. And that can come again with dehydration issues, that can cause airway issues, and anything else that come with a lot of vomiting. These people, not much you can do as an EMT. We can give them medication as medics that can hopefully stop the vomiting, but that does not always work. So we carry Zofran, which is antiemetic, which can, in many cases, reduce the vomiting, but not in all cases. a synthetic marijuana known as spice, very similar to bath salts. People would smoke this, and they basically, as I mentioned, with bath salts, they get super agitated and hallucinate. With spice, they pretty much just fall down to the ground and just lay there many times. And then as soon as that spice wears off, in 20 minutes, they're up and they're gone. You have your hallucinogens. You have your table there that talks about commonly abused hallucinogens. DXM would be your cough syrup kind of things known as Robies, which people would drink Robitussin DM. You have what we call Skittles, or your triple C's, which would be corticetin cough and cold medicine. You take enough of them, you start to hallucinate. Your classic hallucinogens are going to be your shrooms and your LSD. You have your good trips, you have your bad trips. With your good trips, people will tell you, they're seeing great hallucinations, visual and hearing hallucinations. They separate from reality. Bad trips, they think they got bugs crawling all over them, and they start taking a knife and trying to cut the bugs off their skin. They think they can fly, and they jump out of a building. They don't always feel pain. So these are the ones when, if they become combative, it's hard to control them because they don't respond to pressure points and stuff like that. So things that you're going to see with someone having a bad trip would be hypertension, tachycardia, anxiety, and paranoia. As medics, we can sedate these people as needed. As EMTs, you're looking at physical restraints as needed. But again, if they're fighting, just remember, when someone's fighting you, it's just going to increase their agitation, which is going to increase their heart rate, which can then lead to things such as cardiac arrest or stroke. So as with all overdoses, anyone who's agitated, we're going to do the best we can to use our calm and professional manner. As you get into the field, you're going to be able to read patients. There is sometimes a time and place to raise your voice in an attempt to control the situation. But again, that's something that comes with experience, with that time and place. When does that raising the voice and giving a command, when is that going to actually help the situation? And many times it will make that situation worse. So provide emotional restraints. Do not use restraints unless you, provide emotional support. Do not use restraints unless you feel that the patient's a danger to yourself or others. Be careful with these patients. Again, they can appear calm one moment and then become extremely agitated and aggressive another moment. We have our anticholinergic agents. These block the parasympathetic nerves. These are going to be medications such as atropine, Benadryl, Jimson weed. These people, when they overdose on these, can go from being normal to having a seizure, coma, death within 30 minutes. We've had a little rash of these a few years ago. We probably had like 5 or 6 teens die from Jimson weed overdose in a short period of time. It sort of comes in waves. I have not had a Jimson weed overdose in some time, but they do seem to come and go depending on what became trendy, who read a book that talked about it, and their friends go out and they find it and they use it and they all die. Not much we're going to be able to do for people who overdose on this other than monitor their airways. We have our cholinergic agents. These are going to be nerve gases. These are chemicals that are found in chemical weapons, but also your insecticides and pesticides. All right. 2 of the mnemonics that they use, one is dumbbells, diarrhea, urination, meiosis, which is the pinpoint pupils, bradycardia, emesis, which is vomiting, lacrimation, which is tearing eyes, seizure, salivation, and sweating. So every fluid that your body can produce is coming out of your body. Another one is sludge. You can see the definition of sludge here. If you have someone who's been exposed to these, this is a hazmat situation. Hazmat they have the medications that can treat these patients. Even us as paramedics, we don't carry enough of the atropine needed to reverse the effects of someone who overdosed on these patients. If they're exposed to it, they definitely need to be decontaminated. That takes priority over any sort of treatment. Hazmat team takes care of all of that. Once they're deconned, we take care of the airway, breathing, circulation, rapid transport to the hospital. The antidote kit, this is your Duodot auto injector. Our hazmat teams will have these, military will have these. It's a single auto injector. See it in the movies. Those of you who've done military time have probably been trained on them. It's like an EpiPen, but it contains atropine and paroxysmine. I believe that's how you pronounce that. Miscellaneous drugs. Reality is, if it's a pill, someone's going to abuse it. I've had kids that were taking a whole bunch of clonidine a few years ago. Not my kids, but students at the school I teach at. Clonidine will cause the high blood pressure medicine. It causes your blood pressure to drop, which becomes you have decreased perfusion to your brain, so you get all lightheaded and goofy. Other drugs that we see people overdose on that tend to be for suicidal patients, aspirin. Aspirin is a pretty significant blood thinner. It causes nausea, vomiting, hyperventilation. It can cause GI bleeding, ringing in the air, ringing in the ears. Not much that we can do. Again, this might be a drug that we can give activated charcoal for if it's within an hour of the person taking them, and if the patient is able and willing to take the activated charcoal. Again, contact poison control. Make sure it's the appropriate treatment. As long as it's okay for the poison control and your medical direction, consider activated charcoal. In the meantime, monitor airway, breathing, circulation. Acetaminophen, extremely damaging to the liver. Again, we treat promptly and aggressively, get them to the hospital, consider activated charcoal if it's appropriate. We have certain alcohols that people will abuse. People will drink hand sanitizer. People will try to make homemade alcohol that's made incorrectly. It can cause blindness, it can cause kidney failure, seizure, coma, death. Food poisoning is another toxicological emergency. This is something that you might want to take the food to the hospital and let the hospital test it. It's not necessary. At least food is not going to cause a major danger to the ER if you do take it. If they don't want it, they can toss it. You just don't want to not take it and then you get yelled at by the hospital for not bringing it. So most food poisoning is caused by some sort of bacteria that's contaminated what was eaten. These bacteria, the organism will cause toxins that cause the disease. Salmonella, GI symptoms, looking at 72 hours. A lot of times, with my experience, food poisoning usually occurs within a couple of hours of the ingestion. We're looking at nausea, vomiting, abdominal pain, diarrhea. All right, you have your Staphylococcus infections that can produce toxins in food. Just because the food has been cooked doesn't necessarily mean if it was had gone rotten or has the bacteria in it, because the proteins of that bacteria can still be in the food. So it's not always about cooking the bacteria out of the food. That definitely is helpful, but we're looking at things that might actually stay in the food even after it's been cooked well. With Staphylococcus poisoning, think about leaving your food out, food left in a car. Think about that egg salad that was at a picnic, and it's the Tucson summer, and the egg salad has been out in the heat for an hour. What bacteria has grown in that bacteria since then? Botulism is another one. This one tends to be from those improperly canned foods. They're neurologic, so you're looking at blurred vision, weakness, difficulty in speaking and breathing. For EMS, not much we can do for this. Monitor the airway, assist with breathing. If necessary, rapid transport to the hospital. With us, for GI issues, for medics, we're going to give them an IV. maybe can give some anti-nausea medicine, transport them to the hospital. In most cases with food poisoning, the person can stay at home and treat themselves. But when you're looking at the elderly and the very young, dehydration becomes a big issue, and they become hypotensive, tachycardic, and they're going to need to get IV fluids at the hospital. When we have that food poisoning patient, we want to ask them questions. When did they eat last? Did anyone else in your family eat the same food? Are those people also sick? Uh, when you have two or more people have the same illness, think food poisoning, especially if it's coming soon after they ate a meal. Plant poisoning, depending on where you're at in this country, we have some plants that are pretty toxic. We have your poison ivies, your poison oaks. It's a contact. It can get on clothing. So you might not even realize that you have the oils from the plant on your clothes. Someone does your laundry for you, and they end up coming in contact with those toxins. So with plant poisoning, assess the airway, notify poison control. If you decide to take the plant to the emergency department, make sure it's safe in a plastic bag where it can't get anyone else exposed. Clean the site off with soap and water. A lot of people will treat these at home with Benadryl cream, cortisone cream to help with the itching. I have seen poison ivy get into the airway. If people were having a rubbish fire, getting all the plant waste, they didn't realize there was a bunch of poison ivy plants in this pile. So when they set the pile on fire, that smoke contained the oils, the poisons from the poison ivy, and people who inhaled that smoke ended up having reactions inside their airway. And some people are very sensitive to things like poison ivy and poison oak, where the rashes become almost systemic, and that's going to become a trip to the hospital. For us as medics, it's the Benadryl, it's going to be the IVs, it's going to be airway management. Okay, the rest of these are just going to be some review questions. So go through these review questions. If you have any questions about them, when we do our question answer period, we can answer those for you. Already these lectures are not the most exciting way to get this material to you, but please save those questions that you had. So when we do our question answer period, we can hopefully get them all answered for you. Thank you.